has one of two reactions: is people either don't know about it, or they think of it in the context of end of life care. And so there was actually a survey that was published of almost 8,000 Americans. This was published about 2 years ago. And it was about awareness of healthcare circumstances. And 75% of the respondents, this is the representative of the general public, had no idea what palliative care was. And so what you're starting off with is a field that is a subspecialty of medicine that's not really known. But then on top of that, what you have is that those who do know it, they think of it in the context of end of life care. And so what this means is that there's been a concerted effort within the palliative care community, as well as within the oncologic community, to present what the field actually is, which is comprehensive, holistic symptom management for any person and their family with an advanced illness. And so it could be cancer. It could be curable cancer. It could be incurable cancer. It could be heart failure. It could be liver issues, kidney failure, whatever it may be. All of those fall under the umbrella of conditions that can be helped with a palliative care team on board. And so what that has meant for us is to consciously work with our clinical teams to share the type of work that we do, which is symptom management. Everyone has symptoms. Many times it's a symptom that precedes diagnosis. And the symptom persists through treatment. Symptoms may even exacerbate through treatment. There are no points to suffering with the symptoms as someone's going through cancer treatment. So you might as well try to get as many of it under control as possible. So that in a nutshell is what I think of as palliative care, especially in the context of cancer care.
And what made you interested in palliative care when you were going through your training?
So I grew up in a medical household. My parents are physicians. I've been around people who've been ill pretty much my whole life. And my mom is an oncologist. So I literally grew up in an oncology clinic. Like the school bus would drop me off in the clinic. I would hang out. I had my space. There were popsicles in the infusion room fridge. I mean, I was in a good place. So taking care of others during times of life-altering illness is something that is a part of my DNA. I grew up with it. I always knew I wanted to go into oncology. And as I was going through Onc Fellowship, I recognized that the elements about oncologic care that inspired me the most was the ability to optimize a patient's experience as they're going through cancer treatment. And so that's a multidimensional mission, right? It's anything from operations related changes that could streamline their cancer care. It's also related to their approach and decision-making in cancer care and how they do during cancer treatment and life after. And then the fourth dimension is how the people around them, the people who care about them the most, do during cancer treatment and after. And so during Onc Fellowship here at MD Anderson, palliative care is one of the rotations that we do. And we spend a whole month here as oncology fellows. And so it was one of those moments where as I went through the month here, I knew that I had found my tribe, if you will. And so it's that feeling that you're supposed to feel when you fall in love and this and that. Yes. And like, I had it with palliative care. And so I knew that I knew that this was where I could make the most difference and where I could really focus my energies and feel fulfilled at the end of the day and at the end of a career. And so I was thankful to be in a place that had both oncology training as well as palliative care training. So I did a year after my Onc Fellowship. And the environment was such that, and the mentorship was great to where I could transition to a faculty position here. And so it's been home base now for how many years, Lisa? I've lost track, but at least 3 babies ago was when I first came to MD Anderson. So, but yeah. Mm-mm.
Oh, go ahead, Wendy. I'll let you ask a question.
Lisa can read my face.
I
I think
know.
I think we still struggle as a community, as an oncology community, of telling the right story, of describing what palliative care is,
Yeah.
and what to palliate means. And I think some of the confusion or some of the misconception comes from how does hospice care or end of life care tie into palliative care, and are they the same? Are they related? Is there overlap? What's the difference? And there's some kind of differences between adult hospice care and pediatric hospice care that we can get into. But I think there's misconceptions around those two words, because if you look at like the definition of palliate, it's for relieve symptoms, right? And as physicians, that what we do is to relieve symptoms. And so, we should do those things. And so, do you have any kind of thoughts on that from the palliative care community about the words hospice versus palliative care, and how we can better introduce symptom relief to our patients and our families?
Absolutely. And so, palliative care as a field grew out of the need to mitigate suffering at the end of life. The founders of the field, people have been dying since the dawn of mankind, but as a field of palliative care, it really only came together about a little over 8 decades ago. And this is after seeing person after person truly suffering at the end of life. So that's where the field, the nidus for the field developed. So hospice care, end of life care is a continuum, right? It's a continuum of life events. So you're born, you go through life, you have comorbidities, you have symptoms related to the comorbidities, and at some point you pass away. That's the same thing for everybody, regardless of what the circumstances are. And so hospice care is a service that's engaged to make the end of life experience as dignified as possible. And so hospice care is engaged, for better or worse, at least a while back, it's been engaged way too close to somebody's passing. It's not a service that you call for the first time as somebody's taking their last breath. They can provide services in the months leading up to somebody's passing. And so that's hospice care. It's a very distinct entity. In the context of adult medicine, what that is you as a patient have made a conscious decision to forego additional treatments for your illness for any number of reasons. In cancer, in oncology, it's usually because there really isn't a good treatment that would meaningfully extend a person's life without causing significant side effects or without causing harm. Another way to think of it is there aren't any treatments that could actually help more than hurt, meaning you're in a place where taking more cancer treatment could actually take time away from you. And so that's the right time to engage hospice care. You could be up and about, you could be walking around the neighborhood, you could be feeling good, and you would still be eligible for hospice care. And so that's how we contextualize hospice care in the context of general medical care, whether it's oncologic care or cardiac care or whatever it may be. Where we as palliative care teams fit in is that as you're going through that illness, we can help optimize your symptoms at any point in your illness trajectory. And if and when you reach a point where the treatments out there aren't a fit for you, for your illness, we will help you transition from the palliative care team to the hospice team. And so we try to put it as a continuum of whole person care. And it's the nuances of the delivery, the nuances of the how it's done is very neighborhood dependent, geographic dependent, insurance dependent. So, and country, where you are in the world, it's heavily dependent on that. So the framework is hard to explain without knowing exactly where that person is on this planet. But that's a general principle. Symptom management, symptom management, symptom management, Closer to the end of life, transition to hospice care.
I think, Lisa, correct me if I'm wrong. I think this is across the country, but a lot of our listeners are either teenagers, young adults, kind of under 18, or parents of children with sarcoma. And in pediatrics, they can receive concurrent hospice care and cancer-directed therapy, which is different than somebody who's an adult. But I think a lot of people have experience with hospice for, grandparents or parents or whatever. And then when they have a younger person who needs hospice care or palliative care, there's some slight differences, which we appreciate because it gives us options if we want to have options. I think that's just important to be said because there are going to be people who have experienced it differently.
Absolutely. That is a very important distinction, for sure. The core of hospice care, regardless of what age bracket you fall in, the care is brought to you in your home. You don't have to spend your precious time, and energy getting into the car, going to a doctor's appointment for every single thing. Hospice care brings care to you at home. And so if you're in the pediatrics group where you're continuing your cancer treatment, even better, those are less visits to have that are not directly related to your cancer treatment. And so it's really patient-centered care, person-centered care.
I'll at least ask questions. I always have some.
So I know, one thing with palliative care, like you said, because it's symptom management all the way through, so from the beginning. So can you talk about why is it so important to bring in the palliative care team in the very beginning, even when somebody is first diagnosed with cancer?
Right. The palliative care is comprehensive symptom management at any stage of illness. If you're looking from the outside, it can seem like a very touchy-feely field. But the reality is everything that we do is data-driven, including why you should get palliative care involved. That's part of the reason why we have such a robust research component to our palliative care department here at MD Anderson is we want to continually demonstrate the value added, the benefit to the patient from engaging a multidisciplinary subspecialty palliative care team in their care. Integration of palliative care has shown to improve symptom control, whether it's improved quality of life, whether it's improved pain, improvement in mood, improved quality of communication with the provider team, better prognostic understanding from integrating a palliative care team in their care. It's better satisfaction, both patient satisfaction as well as caregiver satisfaction. And it's better advanced care planning, having your wishes on paper. It doesn't matter if you don't have a single medical problem or you have metastatic cancer that's relapsed. Advanced care planning is something all of us should give thought to and share with others. So engaging a palliative care team has shown to improve rates of that. It's engaging palliative care also results in cost savings. It's decreased healthcare utilization, where elements of care that are not in line with your values, whether it's overly aggressive care or procedures and steps and mechanical ventilation, ICU stays, whatever the metric is, each of those metrics, there's strong data to demonstrate that integrating a palliative care team results in a higher proportion of patients getting goal concordant care. So there are two key components to recognize. By engaging a palliative care team, you as a patient are not depriving yourself of frankly anything. It's purely embracing the opportunity to have a better quality of life through treatment and have a better, more prepared plan for the future, whatever the outcome may be. And so each of those statements is backed up by a randomized clinical trial where the standard of care arm of patients got the usual care and the intervention arm got to see the palliative care team. So that's how we know that engaging the palliative care team results in better outcomes. So that's why you see palliative care being integrated into the guidelines of every major organization. in the context of care of people with advanced illnesses. So it's a win-win-win for everybody involved.
How are we doing as a community, as an oncology community? How are we doing with the integration? Because I can speak for, my experience at one institution and then another. There's differences, but how are we doing with these concerted efforts to be more integrated?
So this is where you see the gap between the need and the bandwidth. And so the need is however broadly you define it. As a field, palliative care is relevant for every single person who walks on this planet because it's about symptoms. It could be any symptoms. And it doesn't have to be physical symptoms. It could be significant, emotional symptoms. All of those are relevant to palliative care. So in that context, the catchment is incredibly big. So let's say we're aiming a little bit smaller, a more focused population than, planet Earth. So even if we focus on people with cancer, you're still seeing where there's a vast gap between the number of providers, clinicians who are trained in palliative care, whether it's physicians with subspecialty training in palliative care, board certification in palliative care, or advanced practice providers or other members of the multidisciplinary team. There simply isn't even an order of magnitude equivalence between the need and the bandwidth. So what that has meant is that the clinicians may have an awareness of palliative care, and they have an awareness of palliative care in their practice setting. So in order to close the gap, there are many centers that say palliative care can only be made available to people who are at the end of life, which is very unfortunate, but it's just them trying to reconcile with the bandwidth that they have. There are other cancer centers where they have specific criteria. You have to have advanced cancer or cancer that's relapsed on prior therapies. All of this is a way to just reconcile with the need and what's actually possible. So the variability in the depth of palliative care accessibility is really staggering. That's part of the reason why some of the advocacy efforts by our national palliative care organizations have centered on dramatically increasing the funding to educate a substantial number of new clinicians to dispense palliative care. Because this is not about, figuring out a more efficient workflow within Epic or anything like this. Is literally, you just need more people doing it. And so
I think access is so important. We have a lot of access to palliative care physicians here. And I think for me as a practicing clinician, just having them sitting there in clinic with me and being able to come out maybe unexpectedly and say, oh, hey, I need your input, or this person would really benefit from you. Having that easy access to them has been extraordinarily eye-opening. And then once you know, and once you get it, and then you realize how much having that other person on the care team from the beginning opens up room for me to do, the tumor-directed things that I need to do, and leave space for you, great things you do, and we can all be good at the things that we like, and that we have the time for. So I've definitely, from a provider side, it's been really incredible to have a true 5 days a week palliative care around the corner, cooking coffee. So
yes, no, you hit something right on the head, which is how the time and the appointment is spent. So in the oncology setting, the questions that center around disease management, right? So what is my cancer? What is the histology? How aggressive is it? Where has it spread? How do you treat it? How often do I have to get treatment? How long do I have to get treatment? What are the common side effects? How am I going to feel? I mean, we could just go on and on just with the disease management, and that's a good hour right there. And so we haven't gone to any component of how that person's doing. And by we, I mean, it's the system, right? It's not that all of our hearts are in the right place, but you physically can only do so much in a visit. So when someone comes to see me in the palliative care clinic, we may spend half a second acknowledging the actual cancer that they have, and what treatment that they're on. But that experience of going through cancer is so universal. It's so unifying. It doesn't matter how much money you have or don't have. It doesn't matter who you know or don't know. It doesn't matter what language you speak or don't speak, where you are in the world, who you worship, who you voted for. Like none of that matters when you're going through the cancer journey. And so in our clinic, it's an all-comers clinic. We don't have a separate palliative care clinic for pancreatic cancer or, sarcomas or whatever it may be. It's everybody comes to the same place and we have the same conversations. And it's always centered around the person. We talk about symptoms, we talk about pain, we talk about, nausea, sleep, distress, anxiety. What are the stressors in life? How are the stressors interplaying with one another? And so there's something so unifying about a palliative care visit because it doesn't disembody symptoms. You're not going to a pain clinic. You're not going to a left fourth toe clinic. It's like you're one whole person, and it's just it's that's what the conversation is on. It's not about the cancer. Yeah.
I know you have a question. It rolls right in. Talk about
that is what I was going to ask you to kind of walk us through a clinic, because I know, some things that people might think about is, of course, pain, because a lot of times when you think about cancer, you think about having pain. And then I think just because I had worked in pediatrics, I always think about poop and about Miralax and that. But then other than that, because as Wendy said, when I've had the opportunity, when I was seeing patients working with palliative care, I always learned so much because we don't learn as oncologists how to manage all these symptoms. But I was wondering if you could speak to a little bit, what else palliative care helps with these other symptoms that aren't medicine related, like how else do you help with either integrative medicine or from a psychological standpoint and that kind of thing?
Sure. It's taking me all my restraint to not break out some slides right now because I'm ready to, I want to show some visuals, but
you can.
Don't give me that option because I totally will. But anyhow, a palliative care visit. So there's pre-COVID and post-COVID. So
yeah, that's a good point.
It's the same multidisciplinary team. It's just whether we see you in person in clinic or we see you by Zoom right now. And so it takes a village to deliver palliative care. Effective palliative care is never one person sitting at a computer in a clinic trying to do the job of 20. So who are the members of our multidisciplinary team? Say that 100 times. In our clinic, it's a palliative care physician. All of us are subspecialty trained in palliative care. We're board certified in palliative care. 3/4 of us are from internal medicine backgrounds. The others are family medicine. A good 4 or 5 of us are also trained in geriatrics. And then there are 2 of us who are also trained in medical oncology. So your primary clinician in the palliative care team is a physician who has dedicated their professional identity to symptom management. We have physician assistants and APPs who also go through separate training in palliative care, nurses with a separate training in palliative care, PharmDs. So we have an embedded pharmacist in the clinic with an expertise in symptom management medications in the context of oncologic care, all the buffet of meds that go with cancer care. They're in the clinic, I'm still in the clinic, is our social worker. Our social work counselor is physically in the clinic. There's also our psychosocial team is there. The counselor is in the clinic, as is the clinical psychologist. And then a phone call away is case management, physical therapy, occupational therapy, nutrition, chaplaincy, also a phone call away, and a couple of others I'm forgetting that I'll completely regret later on. So I say this because When somebody comes to see us, it can be 15 minutes. And if they want to spend 3.5 hours with us, they are more than welcome to. We have several people who do. But because they have needs that can be specifically met by different members of the multidisciplinary team. And so if there is spiritual pain, if there is difficulty reconciling with what's happening in the context of their faith, I can help with that. The counselor can help with that. The psychologist can help with that, or the chaplain can help with that. If it's understanding caregiver distress, the psychologist can have a split session where they meet with the patient and then they meet separately with their spouses or their primary caregivers to understand what their needs are, how we can help them, and offer counseling to them. The integrative medicine team is just one consult away. If there are holistic ways to approach coping, symptom management, whether it's fatigue or pain, they have acupuncture through there. They have oncologic massage. I just love the sound of it. But they have a whole month full of classes, whether it's Tai Chi, Qigong, therapeutic drumming, cooking classes. And those classes are all open. It sounds amazing, right? So they had to take a COVID hiatus, and so they resumed some of it online, but obviously you have to have a drum at home if you're going to do Zoom drumming, but you get the point. So I say this because it's whatever that person's needs are. The very first visit and every visit, they always see the physician and the nurse. So, and if needed, the pharmacy. But these two groups, we always tell them that here are all the other people who are ready to help in your care. They can help today, or they can help tomorrow or at another time at your convenience. And so that visit being 15 minutes doesn't mean that they have any less in-depth time with us. It's that either they feel that they're coping well, they're doing well, or that this is not a good time to stay longer. They want the counselor to call them back. And so it's getting plugged in with the team so that your care can be continuous, even between clinic visits. And so those are just some of the domains that we cover, but it's truly a multidisciplinary effort, for sure.
Yeah, I think that's just so amazing, because it is true that even though a lot of the themes are the same and the stories and needs are the same, everybody is an individual and needs and responds individually to different things.
Yeah, absolutely.
And then one thing I was going to ask you about, because I saw you did that meta-analysis on the caregiver. And I think that related really well to adults and pediatrics, because, pediatrics, everybody has a caregiver. But adults, many older adults who are the group that get cancer as well, they all have a caregiver. And I was just wondering if you could speak a little bit to that, because I think the caregivers never are thinking about themselves because they're just thinking about the person they're caring about, but they will burn out, just as quickly.
Absolutely. The caregiver experience is one that's hasn't really been on the radar of medicine for the longest time, right? And it's really only more recently that we're recognizing the experience that the caregivers are going through. I gave a talk, this was about 3 years ago, and about caregiving and cancer caregiving. And I had, this was a patient conference, and a gentleman came up to me after, and he was talking about how much of what was presented resonated with him, and how in the context of his spouse's cancer diagnosis and him taking care of her, he developed, or he had several health conditions that either developed or kind of rose up to the top as a consequence. And he also talked about how he hadn't fully sought medical attention for those. And so there are several elements about cancer caregiving that fully need to be understood. The first is that it's the unpaid informal caregiver. That's the official academic designation versus somebody you pay to come take care of somebody. they're the backbone of oncologic healthcare systems. If their services had to be compensated for, like if they could bill Medicare for caregiving time that they did, the system would be bankrupt within a week. And that's data that's been demonstrated. So the services that the caregivers provide, the informal family, friend caregivers provide cannot put a price tag on it. The second is the caregiver is going through the medical event with that patient. So they are as emotionally and physically invested in it as them. So if they are reacting in any way, whether it's emotional reactions, physical reactions, if their blood pressure is going up, if they're having trouble sleeping, if they're having anxiety, trouble focusing, if they're feeling really down, that needs to be addressed just like any other medical problem. So caregivers getting care with their primary care doctor or with a subspecialty doctor to help them during this time is absolutely crucial, absolutely crucial. And that can be a host of general medicine needs. It could be mental health needs, whatever needs they are. That's step number one. And step two is to really, truly try not to take everything on yourself. We wrote about this and we discussed it actually at the 2019 ASCO annual meeting. And it was about how do we engage platforms on social media to help the cancer treatment experience of our patients. Some of them centered around apps and interfaces where families or a single spokesperson could put the needs of that family there. And those in the community who want to help them in their support circle sign up for those tasks. It could be, it could be meal trains, but it could also be chores. It could be whatever they need. And so we want to empower our caregivers to recognize that they are going through an experience and that they need as much support from the medical community as well as their support community as they go through it. Sure.
That's we obviously see it all the time, and it's a dream of mine that we'd be able to seamlessly integrate, support in a way that is easy and not extra. Hashtag pipe dream goals. I don't know what you want to call it, but I think afterwards, all of our families, no matter what happens, once they finally found their feet again or not, that experience is universal and traumatizing. I think we just have to acknowledge that we need trauma-informed care for our caregivers after, etc. So, yeah, it's a lot.
It's a lot. And I would, and this is my one of my pipe dreams, which I shouldn't say pipe dream. It is totally doable.
I changed it too. I was like, no, it's not a pipe dream. We just got to make it happen.
It's this is where I have to say I definitely speak for myself and not for any organizations or employers. But I envision these tandem appointments where the caregiver is also getting care with me in a supportive care environment, because the services here are as much relevant to them as they are to the patient themselves. And I want that formal appointment relationship because a component of care does involve medications. It doesn't have to exclusively hinge on medications, and it may not start out with medications. But in most circumstances, the well-chosen tablet can complement a multidisciplinary approach to the management of a symptom. And so as I can talk a caregiver into oblivion, but I can't actually do that multidisciplinary treatment for them. Mm-hmm. And so I'd like to think it's not unreasonable to have tandem appointments where the caregiver sees me the same day as, the patient sees me. It could be separate visits or, whatever the logistics are, but I guess culturally, you can't, it's hard to, I guess there really hasn't been conversation or acceptance of having the caregivers establish care with the practice. It's almost like, go see your primary care person. I mean, I get where they're coming from in that I get it. And maybe that's where the integration will need to happen, is that. But yeah.
I agree. I don't think it's a pipe dream. I think it's something. I think we have to have people like you who are forward thinking about it. Not just pediatrics people too, you know, because our problem is that we're pediatric board certified. And so then we really do have a problem with adult patients. Both, or here at Mayo Clinic, they do both. There's opportunities, but there's standalone children's hospitals where our parents need help and we don't have the resources for it because we're certified in the wrong thing. And so, but palliative care is that crossover, and so it can be done. And
I'm telling you, so, you know, our training is, you know, we go through pediatrics through older adults. And so and many of us have come in contact with the healthcare system with our own families, right? For one reason or another. So you can see elements of the experiences. And again, depending on how serious the illnesses that are within our family, you are experiencing parts of the system, and you can also see how it doesn't have to be that complicated. This patient-centeredness doesn't have to come at the expense of, you know, revenue or whatever else that may be important to others, but just more, you know, thoughtful organization.
Yeah.
Not a pipe dream. I like that. This is good. We can make this happen.
Exactly.
Our forward old vision or something.
Here.
So we're getting to the top of the hour, so I see your mouth wanting to say something. I'm going to be quiet.
Oh yeah, well, I was going to say that, and then just ask Ishwaria if she had anything else that that she wanted to say before we wrap up. We definitely want to have you on again because I think there's more to talk about, and this topic is so important. But anything that you wish that you would get asked more, that you, or anything like that you want to tell us or share with us.
You know, frankly, each symptom and domain that we cover in palliative care, we could spend a whole hour talking about those, whether it's pain or nausea or sleeping or appetite or mood or whatever it may be. So
we might have to have you on 10 more times.
Well, it's one of those things where you know, I'm at the end of my clinic today, and so I don't want people to think that just because they have a diagnosis and are going through treatment that they have to suffer because of it, and that sucking it up is a good thing. There are no bonus points to suffering during cancer or cancer treatment. There may be elements of the suffering that can't be helped, but there are elements that can be helped. And so if there's ever a time to seek symptom management, it's during and after cancer care.
Yeah, sure. I like, there's no bonus points, no style points.
Absolutely.
Yeah. No, thank you so much. Yeah, this has been so great, and we definitely, yes, we have a lot more that we can talk about and will talk about too. So thank you for giving us time today.
Of course, it's been so much fun to talk to you both. I really appreciate you making time for this important topic and to engage me on it. Yeah.